And now comes the part we've all been waiting for, the counterpoint imaging in acute diplopia for patients over the age of 50.
You're on.
I'm on?
You're on.
So we have just a couple of minutes to talk about why patients with acute third, fourth, or sixth nerve palsies who are over 50, that is in the microvascular age group, should be imaged. And I think we have two papers. We published a paper in 2004 with Kelvin Chu as the first author, looking at 66 patients prospectively, and we had 16% had a non-microvascular cause, aneurysm, brainstem infarct, aneurysm, demyelinating disease, and pituitary apoplexy. We followed that study up with a multi-center study with Emory, Wilmer, Colorado, Minnesota, and we had 109 patients, again, studied prospectively, and there 16.5% had some other condition other than microvascular. And here the giant cell comes up. Some of the patients had giant cell. There was a cavernous sinus lymphoma, another midbrain infarct, meningioma, and again, apoplexy. Even if you take out the third nerve palsies in the giant cell, 5% had another cause. So I think these rules about pupil sparing, incomplete, whether you should wait, these were all more useful when, as Nancy suggested, when the workup was much more invasive, formal angiography, air exerted and inserted into the ventricles, but neuroimaging is so readily available and non-invasive. I think that all patients with these acute third, fourth, and sixth nerve palsies isolated should be imaged.
That's the pro. Do we have a con argument?
I'll be contrary again. Well, economics is all about the allocation of finite resources in a wise fashion. And neuroophthalmology is all about making the best judgment possible, weighing the risk-benefit ratio. So I'm not here to tell you that you should never image these patients, but I am here to tell you there are many cases, probably the majority of cases, when you don't need to image these patients. The first question is acute diplopia. Remember that acute diplopia does not always mean that the etiologic factor was acute in onset. You may have had a long-standing fourth nerve palsy. The awareness of the diplopia may come because of loss of fusion amplitude. So history of prior episodes, prior strabismus, old photograph review, things like that are very, very important. And in fact, if you look at, I think, some of the papers that Grant talked about, it's not so much the presence of diplopia, but the presence of ophthalmoplegia that is the biggest risk factor for finding a causative etiology on neuroimaging. Some things that should make you less concerned are comitant deviations, vergence insufficiencies, convergence, divergence insufficiency, prior strabismus, and nowadays we know from the work of people at UCLA and others that extraocular muscle pulley dystopia, which is common in myopes and aging people, is a common cause of esotropias and vertical strabismus in this age group. So if they're in that age group, they're myopic, they have deep-set superior fissures, things like that, that can allow you not to image. Now, we're going to take out, of course, the pupillary involving third nerve palsies. They all have to be imaged, and as Grant mentioned, once you take those out of that paper, the yield went down by a factor of 1/3, so that's very important. But these are things I think that you don't have to image for. If you have a truly isolated mononeuropathy or cranial nerve palsy, it means vision's fine, visual fields are good, there's no disc swelling, no uveitis, anything else that would concern you would prompt you towards imaging. Obviously, giant cell is an important consideration, but that's not something that needs to be imaged. If there's no history of trauma, that's as well. If there's no prior history of cancer, and if the patients are indeed vasculopathic. So isolated cranial or mononeuropathies with no trauma, no cancer, definite vasculopathic age group or past medical history, I think you can watch these. Now, obviously, if they don't get better in 6 weeks, if they don't start to improve in 6 weeks, you got to image them at that point. So what about the resource issue? Well, Peter Savino's group has a paper where they found out of almost 100 patients that were imaged for these episodes, these isolated cranial mononeuropathies, only one had a causative etiology show on neuroimaging, and it was not anything that needed to be treated. And it was an infarct in the pons, I think, and it went away on its own. So, you know, their calculations, it was about $130,000 were expended to find one causative etiology that did not need to be treated. The other side of the coin is, you know, what could you miss that's really bad? Well, a lot of the things that you may miss in these isolated cases, maybe things that are not acute, myasthenia, MS, a meningioma is a common cause. So, you know, my point again is not that don't ever image these, but there is a large group of patients with concomitant deviations, chronic problems that have sudden onset of symptoms, and these isolated cranial mononeuropathies without trauma or cancer and with definite vasculopathy, you can watch those for a while.
All right, we now will have a short rebuttal back on the pro side.
Who are you calling short? Okay, how many of you out there who are not neuro-ophthalmologists really want to take care of these patients? Yeah, that's what I thought. Okay, so I think what Mike said is absolutely true. Certainly, if this were a question of do you image every cranial ocular motor nerve palsy in patients over 50, it would be different than do you image every patient with double vision over 50. And certainly, if you can come up in your office very quickly with an alternative diagnosis, such as it's an obvious sagging eye syndrome, or it's an obvious breakdown of a strabismus or a congenital fourth like I have, okay, you know, big fusional amplitudes. If you really want to bother with that, you go for it. But if you have diagnosed a cranial nerve 3, 4, or 6 palsy, number 3, no question, should be going to be imaged with vascular imaging at the top. You can get the MRI to find out that it's a meningioma or it's MS or it's whatever later, but they absolutely need vascular imaging. And then, you know what? You're done. Get it to a neuro-ophthalmologist. 4 and 6 we're not as worried about. You can get the MRI yourself if you want, or you can get a consultation. But the one you really, well, the two you don't want to miss. One is giant cell arteritis. You have to just keep that in mind. It can do this. But the real one you don't want to miss is you don't play around with the third nerve. And you just get that imaged, especially vascular imaging, with whatever your place does best and quickest.
And now it's time for our short con rebuttal.
Okay, I'm short as well. This will be very short. I'm pretty much on their side of the table. And it depends on your comfort level.
But you're supposed to be helping me.
Yeah, I'm trying. But okay, for neuro-ophthalmologists, our comfort level is probably way different from the general ophthalmologist at making the diagnosis of an entity that doesn't require imaging for the diagnosis, as some of the cases that were already presented. So myasthenia, really it's the exam findings and some blood tests, if you do pyridostigmine or something, an ICE test. But most general ophthalmologists are probably not encountering that enough to feel comfortable in their exam. A fourth nerve palsy that's a congenital fourth nerve, it depends on how comfortable you are, and are you measuring vertical fusional amplitudes to find out they're large? Did the patient happen to walk in with their photo album from grade school where you can see their head tilt? Some of these things take time and experience, and our comfort level may be much stronger than yours. On the other hand, in some areas of this country, and maybe worse in Canada, we'd have to ask our Canadian from this morning, MRIs and scans aren't necessarily that available like today. So some of the time you may be forced to wait on getting a scan if that's what you're more comfortable with. You have an option of seeing the patient the next day or the day after and making sure that they're not getting worse, which adds a little bit more comfort to the fact that, yes, you're not getting a scan today, it'll be next week or in a few days. So I'm kind of a mixed bag here. Some of the time, you don't have to get the scan to make the diagnosis. I think your comfort level may require that you get the scan more often. Sorry.
Question for the pro side. Patient comes in with an isolated 6th nerve palsy. They've had 2 strokes. They've had 3 heart attacks. They're on every blood thinner known to mankind. Do you image all of those patients?
Yes.
I don't image all of them, but I have the discussion with them. And most often, we have 2 scenarios. They either came already with 2 MRIs under their arm because their primary care doctor got one and their ophthalmologist who referred got the other, and not always the right scan. They get a scan without contrast, and so I really can't assess. And 2 is if they really don't want the scan. They are claustrophobic. They have kidney failure. They can't have gadolinium. They don't have the copay. You know, those are the cases that I'm comfortable enough doing what I used to do 25 years ago, and that is to watch them, because Simmons Lascelles would always say, you never get a prize for being the first person to discover an incurable disease. You know, nowadays you do get a prize because people want to know, and they're going to go on the internet and look things up. And so most often I will get the scan, but I have a conversation. When it's a 3rd nerve palsy, I do not have a conversation.